artificial intelligence is not new. Yes, for some of us, we started hearing it when ChatGPT came out, but it has been around since 1956. So the first time machine learning was mentioned in 1959 at a conference. Then 1969, when a general purpose robot was developed. Then in 1988, when IBM created a statistical approach to language translation, the kind of language translation we are seeing now, it started since 1988. Then in 1997 is when the headlines, the same way we are seeing now ChatGPT, the headlines started in 1997 when the first AI algorithm beat the world chess champion. So basically, in those times, we are trying to use artificial intelligence to show the tasks which are still complicated to human being that can be done by an algorithm in a better way. So the same way we are doing now. But it started in 1997. Then a lot of trends have been happening. As you can see, one of the most common benchmarking data set, we call it ImageNet, which is a general purpose object are being used. Even AI algorithms have been tested on the same object. So the current testing of human, they can make an error of recognizing this object with 16%. But in 2015, Resonate, one of the common algorithms we are using, especially in transfer learning, made an error of just 3.5. So we started showing that even AI can outperform human in other common tasks. Then in 2016, the same company, those people who won, I think it was a Nobel Prize in chemistry, who created they created an algorithm called AlphaGo. They are just graduates, PhD graduates from Oxford University. They created an algorithm called AlphaGo, which beat the world champion of a game called Go, which is believed to be more complicated than chess. So it was just the same trend is showing people that yes, AI, when trained well with good data set, can outperform human in several tasks. So what have really changed from those times when AI was coming to now? It's just mostly on the computing technologies. Initially, in 1956, IBM was just using this whole room computer, and the next speaker, Jamie, just told me Haddad used to work in this kind of computers in those ages. And it was just able to do up to 24,000 operations in a second. Then it came this one. When Apple released their iPhone in 2007 with their first Siri, the same Siri we are talking now, it was released first in 2007, and their processor inside the phone was able to make around 200,000 operations in a second. So you can actually see from this huge size room of computers to just a microprocessor which can fit in a smartphone, and now we have this AMD. So you can see the trend in technology. We're able now people to train this algorithm using massive data sets and on simple computers. I will skip this part. Now, currently, in our research lab, we started with the NVIDIA RTX 3060. That was 4 years ago. Last year, we moved it to NVIDIA RTX A4000. And now we are just waiting for the vector machines, which are more powerful, which now enables us to train this huge algorithm within a short period of time. And the algorithm can acquire human-level intelligence. So basically, whenever we are creating this algorithm, we need to look at this AI canvas. And the main reason why we developed this at Vigro is whoever who is developing this AI algorithm have to look back at this, because most of the time we find companies which develop the algorithms, but they don't have resources to deploy. Look at the way ChatGPT works. There are many companies building on top of ChatGPT, but ChatGPT requires a lot of computing resources to be deployed, and also it needs internet, which we don't have largely in Africa. It can work in urban cities, but in rural areas, we can't leverage ChatGPT. So do we still have to lock ourselves in this kind of technology, or we can adapt other way of using artificial intelligence, which reflects our settings? So basically, whenever you're developing an AI algorithm, first you have to look at the concept. What's the problem you're trying to address? Do you really need AI? Or people start with AI first, then find the problem to fix. So you have to start with the problem. Does your problem really need AI? And on number two is, on data. Most of the time, especially in healthcare, whenever you go to hospitals to collect data, the data set there is not ready for AI machine learning application. It's not working. We know a guy who's based in Uganda trained his algorithm from data set from Scotland for early detection of cervical cancer. It had an accuracy of 97. But when it was deployed in Uganda, those oncologists throw it away. It couldn't work because the infrastructure available in the Scotland were not available in Uganda. The way that data set, the kind of machines were used in the Scotland, didn't resemble the realities in Africa. So do we need those kind of technology? Or we have to adapt our own way of doing it. And also on number 3 is on the model. Which kind of model are you using? Does it need internet? Because in most areas in Africa, we don't have internet. The computing resources, do you still need a device which will need these high-end GPUs I just showed you? Or we just need something which can fit maybe in a smartphone, or even just a smartwatch which can be work remotely. So you can actually see in every other element, because I just have 10 minutes to present, and we still talk about the infrastructure. Is our infrastructure ready for that? Because most of the time we develop things, and at the end, when we deploy them, we find out they're not suitable for in African settings. So yes, we really need artificial intelligence, and some of the use cases, I'll talk a bit about AI for breast cancer. We developed an AI algorithm for breast cancer, and it uses mammogram machines. In Tanzania, we have less than 10 mammogram machines. So if we deploy this kind of algorithm, who is it going to serve in Africa? And I had an engagement from people from the University of Barcelona. They told us they have an algorithm which uses MRI, which is more complicated than mammogram. And they wanted to test it in Africa. But MRI, where do we find them in Africa? Or it is just for a special group of people who can, this technology can help. The same way, when you go to another algorithm that we are working on dilated cardiomyopathy, when your left ventricle dilate, and it can't pump enough blood to the rest of the body, so it's a major contributor of a heart attack. But it needs an echo machine. How many do we have them? The cardiologists, how many do we have them? So you can actually see most of the problem we are trying to address, they need data set from these high-end machines which are not available in our settings. So at the end, it will end up adopt this technology from the global north, and it won't impact people in our setting. This is a van. Inside this van, it moves around Tanzania, and some are actually here in Kenya and Uganda, and I know some are in Zambia. Inside, they have an algorithm called CAD for TB. It's for general screening of tuberculosis. In Tanzania, we have 6 of them. So they need an X-ray machine to be able to get chest X-ray. Then this X-ray can be analyzed by the AI algorithm to detect tuberculosis. And this is how it works. The algorithm was developed by a company from the Netherlands. It's called Delft Imaging. So on your left, you actually see the chest X-ray. It goes into that simple small box, which inside it, there's an AI algorithm, and it can detect tuberculosis. I remember one of the cases, especially on the previous slide, where this algorithm can screen up to 2,000 people in a single day. Something which can't be done by a human. So why do we need artificial intelligence, especially in Africa setting? In my opinion, I think Africa will need AI more than any other part of the world. Because of our already complicated healthcare system, we don't have enough healthcare workers. Like I spoke about the cardiologists, radiologists. It takes like 4 or 5 years to train a single one. Very expensive process. And for that person to be efficient, she or he needs more experience to be able to detect all these cases. And she can perform better in the morning. Then in the afternoon after lunch, the performance will go low, right? Then in the evening, and that's when before the landlord call to ask for your rental fee to be paid. Other things coming along to disturb your performance. But AI can change. So there are several factors, especially on the severe shortage of healthcare professionals, high burden of preventable and treatable diseases, limited healthcare infrastructure, and the list goes on and on. So what should we do now? I'll invite Jamie to talk on how AI is being used in Africa using our low resource settings and how we can leverage the technology instead of relying on these high-end machines to address our challenges. Jamie, please.
Brilliant. Hi, everybody. How are you today? Thanks for having me. So I'm Jamie, and I'm going to present on AI-powered disease screening, revolutionizing healthcare access. So my name, I'm originally from the US. I've been based in Africa for the last decade. I spent 4.5 beautiful years here in Nairobi, so it's good to be home. And I'm now based in Cape Town, South Africa, working with AI Diagnostics, a South African company. So the challenge that we're looking at today, and this photo here, this is the white plague of the 18th and 19th century. Today, it's called tuberculosis, and it kills more people than any other infectious disease globally. But TB is treatable since the 1940s, and so how is this still possible? Healthcare has an access problem. 4 billion people have no access to basic healthcare worldwide. 8 million people die annually due to this challenge, and half of these deaths are avoidable. 10 million healthcare workers are needed if we wanted to solve this access problem. And we know that in Africa, in Asia, in a lot of the places where this group lives, it's just not feasible because that would require $371 billion annually. It's out of the budget. And so what we've done here is we tried to build the tools that are both accurate enough to catch diseases early and accessible enough to scale. At AI Diagnostics, we've developed an entirely new TB screening tool, which uses our AI models to detect tuberculosis by analyzing patients' lung sounds captured with our digital stethoscope, which is right here. It's the size of an apple, and it's designed specifically for use by frontline healthcare workers. So we've developed two things, as I showed you, the Ostium, which is our digital stethoscope, as well as a TB model, which then utilizes our app in order to screen individuals for tuberculosis in the community setting, in primary healthcare settings. Every nurse, every pharmacist, every community health worker could use one of these. This would add 30 million people that could screen for 60% of preventable diseases that cause death globally. And so the way that the screening works is that basic training is required and it's embedded within our app. There's limited demographic and clinical information that needs to be collected. I think we've all used an app that asks 45 questions of somebody before it even tells you a piece of information. We're absolutely designing to avoid that challenge. We then take 6 chest positions where we're collecting lung sounds. If anybody's ever been to a doctor and they say breathe, it's the same thing. There's 2 on your chest, 2 spots on your upper back, and 2 spots on the lower back. We've used our AI algorithm to determine the least amount of breaths needed and the least amount of points needed on the body in order to collect enough information to determine if somebody has tuberculosis. There's 2 breaths per position, and the optimal screening time is less than 5 minutes. In our first study, a single nurse was able to conduct 40 screenings per day, but by most recent studies, that can go up to 80 screenings on one device in a day. And so how did we come to this? Well, we really worked very hard over a number of years. The company was founded in 2020, and unlike X-ray images, large stethoscope audio data sets simply didn't exist. So to build our AI, we had to collect this foundational data ourselves. And without major funding, we set up our own clinical trials and research centers in South Africa, partnered with 33 healthcare facilities, building the largest TB lung sound database in the world. And we've luckily and successfully captured and been able to secure SARPA approval in order to utilize this device in South Africa. So what did that look like? 80,000 lung recordings have been captured, 33 recruitment centers. What we found is that the device is 60 to 200 times cheaper than X-ray, and AI solutions like you just saw, CAD for TB, is typically around $60,000 for the X-ray device itself. And what we often also find is that the minute a piece of that X-ray machine breaks or is faulty, fixing it is very complicated. And what we've also been able to determine is that with 90% sensitivity, we were able to achieve 68% specificity, which meets WHO standards. It also outperforms a radiologist looking at a chest X-ray, and it significantly outperforms what's called traditional symptom screening when you're asked, do you have a cough? Are you sweating? Are you losing weight? And do you have a fever? And so this methodology takes us from the old school to the new school. And so what that evidence looks like, this is actually what our data set looks like, where we're able to adjust our sensitivity and our sensitivity based on the necessity of the healthcare setting. So if we want to be more sensitive and make sure that we're capturing All of our TB cases, we can set it one way, and if we want to be less sensitive, we're able to adjust it so that we're capturing people who may be asymptomatic more easily if that's the concern. And so what this also looks like is a MEL spectrogram, which is how the data goes from an audio to a visual. And actually thinking about what Deo was just talking about, thinking through how sometimes there's things humans just aren't as good at as AI. And even with our own clinician, when he listens to the audio of the lung sounds, he's not necessarily able to detect tuberculosis as effectively as the AI, because the minutia of the sound differentiation is very, very small or needs to be amplified significantly, which wouldn't be able to be done with a traditional stethoscope or in a traditional community health setting where there's significant noises. But with noise cancellation, with AI, with the tools that we're building, we're really focused on how to make sure that the AI is outperforming people. And so the way it works is traditional AI, like we may understand today. There's a data set. It then feeds into a model. The model then screens for disease. The new data that comes into the system goes back into the data set. And actually 70% of the people we've been screening to date have actually consented for their data to be used to retrain our models. And as we grow, they're going to get better and better. And so we're currently starting studies in several countries around Africa and Asia to increase the size of our data set, to capture more populations, to build new subsets, to take in new demographic factors, to include children. So currently the device is only approved for individuals over the age of 14. And in tuberculosis, for anyone in that space, it's very, very hard to diagnose in children. So how can we improve that component? And yeah, all sorts of different research is taking place, and we're really excited to see how it continues to improve our outcomes. And so right now, we've got the TB model and the stethoscope, the ostium, but our goal is to increase our capacity to include new models for things like rheumatic heart disease, asthma, silicosis, anything that a stethoscope can hear in the lungs and in the heart. We want to include in the model so that the device is a single use to replace a traditional stethoscope and improve ability to screen for disease across Africa. And that's my time.